AI in clinical decision support, a lifeline for healthcare. For the past few years, I've spent more time in hospitals than I ever expected, not as a patient, but as family, sitting through ICU nights, deciphering scan reports, waiting in triage lines, and catching hurried conversations with doctors mid-shift. You learn a lot when you're the one asking questions no one has time to answer. However, my proximity to healthcare and its challenges is not new. I have seen it firsthand through my father, who is a doctor himself. I approach this conversation from a deeply personal perspective. Over dinners, phone calls, and the occasional clinical debate, I have had the privilege of observing his world not just as a technologist or a consultant, but as a son. I've seen the silent sacrifices, the skipped meals, the endless night calls, the weight of responsibility carried long after those calls end. That proximity to both the human toll and the professional grind shapes how I see healthcare, and why I believe AI in clinical decision support systems isn't a luxury, it's a necessity. That respect turned even more personal a few days ago when my father, a doctor who has spent his life serving others, suffered a cardiac event. Watching him battle both his health and the very system he dedicated decades to brought a new kind of clarity. In those crucial early hours, I turned to AI-powered tools to help analyze his ECGs and clinical reports. While I don't claim clinical expertise, years of proximity to my father's work have given me a working understanding of how to read patterns, just enough to know when something appears to be amiss. These AI tools didn't just confirm my suspicions, they validated my doubts, amplified my instincts, and gave me the confidence to push for immediate escalation. That decision ensured he received the critical emergency care he needed, without delay. It's not an exaggeration to say that the AI tool spotted risks that a junior doctor might have otherwise missed under pressure. In that moment, AI wasn't a futuristic concept or a shiny demo. It was a vital partner in survival. However, this is not just personal, it's also deeply professional. At Greyhound Research, we have advised numerous healthcare system providers and hospital groups around the world. From helping large private hospital chains digitize their oncology workflows to working with regional care networks in the Middle East on their clinical AI governance, we've had a front row seat to both ambition and chaos. And more importantly, we've seen where it goes right and where it completely falls apart. So let's get into it. Not as hype merchants or headline chasers, but as people who care deeply about getting this right. Because AI in clinical decision support, CDSS, isn't some Silicon Valley sideshow. It's the missing scaffolding that props up an exhausted system collapsing under its complexity. And if you're a hospital owner or part of the leadership reading this, I'm not here to sell you software. I'm here to help you avoid the kind of mistake that doesn't just cost money, it costs lives. What the technology actually does, why it matters. Clinical decision support systems, CDSS, have long been the silent co-pilots in modern healthcare. Their purpose is simple but critical: to assist doctors, nurses, and care teams in making safer, faster, and more evidence-based clinical decisions. A CDSS tool doesn't replace clinical judgment, it sharpens it. By collating vast amounts of patient data, lab results, imaging reports, medication histories, and clinical guidelines, a well-functioning CDSS flags risks, suggests differential diagnoses, recommends interventions, and helps avoid costly errors. In an environment where every second and every decision can mean the difference between life and death, CDSS provides a structured safety net without adding complexity to an already overwhelming clinical load. The role of CDSS now extends across multiple operational domains: patient safety, by alerting for drug-drug interactions and excessive dosing; clinical management, such as automating preventive care reminders; diagnostic support, assisting radiologists and lab technicians; and even administrative tasks, improving coding accuracy and compliance tracking. Increasingly, modern CDSS also interface with patient-facing tools like wearable devices and personal health records, enabling shared decision-making and proactive chronic disease management. Until recently, most CDSS systems were static, rule-based engines, and many still are. They follow programmed pathways. If X, then Y, and are constrained by the biases and assumptions of their human designers. This is where artificial intelligence, AI, changes the game entirely. Clinical decision support systems are broadly classified into two categories. Knowledge-based CDSS rely on predefined rules and clinical guidelines, often structured as if-then statements, to generate recommendations. In contrast, non-knowledge-based CDSS use artificial intelligence and machine learning to detect complex patterns in patient data without the need for explicitly programmed rules. While this latter category holds transformative promise, challenges such as model transparency, often referred to as the black box problem, and data quality continue to limit widespread adoption. Structurally, CDSS are built on 5 foundational components: data management, knowledge management, rules engines, inference mechanisms, and a clinician-facing interface. AI doesn't replace these layers, it reinforces them. At Greyhound Research, we emphasize that a truly effective CDSS must function as a coherent pipeline, where both structured and unstructured data are not just processed, but interpreted and contextualized. Through natural language processing, NLP, and machine learning, AI enables these systems to analyze physician notes, detect clinical trends, and deliver context-specific alerts that go beyond static protocol reminders. AI-enhanced clinical decision support systems go far beyond traditional checklists. These systems consume vast volumes of both structured and unstructured clinical data and surface insights that even seasoned physicians might miss. Natural language processing, NLP, engines can parse through years of physician notes to highlight overlooked risk factors. Machine learning models can predict likely diagnoses based on subtle patterns in patient histories, lab results, and imaging, long before symptoms escalate into crises. Deep learning algorithms can prioritize interventions, recommend personalized treatments, and even forecast patient deterioration before it's visible to the human eye. Yet despite the enormous promise, the reality on the ground remains far more sobering. Most hospital deployments of AI-powered CDSS tools remain surface-level experiments at best. Too often, models aren't trained on local population data. Interfaces remain clunky, disconnected from core EMR systems, and deliver insights that are either too generic or not clinically actionable. Worse still, they can create a dangerous false sense of security when recommendations are based on incomplete or poorly generalized datasets. For AI-driven CDSS to work in the real world, it must be purpose-built for clinical pain points, rigorously trained on context-specific data, and embedded directly into the clinical workflow, not forced as an afterthought. According to the Greyhound Pulse 2025 Clinical AI Adoption Index, 58% of AI-enabled CDSS deployments fail to move beyond the trial phase due to resistance from frontline staff. Greyhound field notes from public hospitals in Southeast Asia, including Malaysia and Vietnam, reinforce this challenge. In one case, a CDSS module designed to flag critical drug interactions triggered alerts during busy patient rounds, but with no time to verify or escalate. Most alerts were routinely dismissed. The outcome was predictable. Clinicians began ignoring the system altogether, and adoption rates plummeted. When CDSS works, it saves lives. When it doesn't, it simply adds noise to an already burdened clinical environment. Getting it right isn't about technology. It's about trust, relevance, and relentless attention to clinical reality. A well-architected CDSS doesn't just support clinicians, it elevates entire healthcare systems. By improving diagnostic accuracy, accelerating interventions, enabling personalized medicine, and preventing medication errors, CDSS redefines what modern, safe, patient-centered care looks like. At Greyhound Research, we believe that future healthcare efficiency will be measured not in faster checklists, but in smarter, safer decisions that truly shift patient outcomes. Advanced AI methods, from classic machine learning to deep learning, are beginning to replace rigid rule-based CDSS with adaptive systems that learn over time. Natural language processing allows systems to parse free-text EMR entries, while convolutional networks are improving triage in radiology. But these gains mean nothing if models are opaque. At Greyhound Research, we routinely see clinician adoption falter when algorithms are seen as black boxes. Trust, not just technical performance, is the true barometer of success. At Greyhound Research, we believe that AI in clinical decision support is not about complexity, it's about clarity. The real breakthroughs happen not when systems are intelligent, but when they're trusted, explainable, and clinically embedded. If your AI can't survive the ward, it has no place in the boardroom. A closer look, global case studies, and deeper lessons. At the Mayo Clinic in the United States, physicians piloted an AI-driven system designed to predict the onset of sepsis significantly earlier than traditional clinical observation. Built on a proprietary machine learning framework trained on millions of patient records, the system continuously analyzed vital signs, lab values, and nursing notes in real time. According to the Mayo Clinic platform, this model has successfully identified over 82% of sepsis cases in advance, offering clinicians a critical early window to act. While exact reductions in mortality and ICU stays may vary across implementations, the impact is clear. Earlier interventions lead to better outcomes, fewer complications, and substantial downstream savings for large hospital systems. What set this deployment apart was not just the algorithm, but the disciplined governance surrounding it. At Mayo Clinic, AI systems are treated as living assets, continuously evaluated, adjusted, and aligned with evolving clinical realities. While not every detail of their governance structure is public, the institution has repeatedly stressed the importance of multidisciplinary oversight in ensuring AI remains accurate, ethical, and usable. In a 2023 panel hosted by the Mayo Clinic Innovation Exchange, leaders across clinical and data science functions shared how they embed governance into model deployment cycles. Separately, a case study from the MIT Sloan Management Review details how Mayo focuses on building AI infrastructure and operational discipline over one-off pilots, a strategy that makes AI part of clinical fabric, not just an innovation headline. In India, Cured AI's QXR, a deep learning tool for interpreting chest X-rays, has been deployed across various healthcare settings to support early detection of conditions such as tuberculosis, pneumonia, and pleural effusion. The tool has received FDA clearance and has demonstrated its clinical relevance in emergency and ICU workflows for triaging critical pulmonary findings. While specific deployment details at Apollo hospitals are not publicly documented, Cured AI's AI capabilities have been evaluated in India to improve TB detection rates and reduce diagnostic costs, particularly in resource-constrained environments. Separately, Apollo Hospitals has been advancing AI-led initiatives through its Apollo Precision Oncology Center, APOC. As detailed in its official publication, AI tools at APOC are playing a game-changing role in early cancer detection. From radiogenomics to AI-augmented diagnostic workflows, these systems help flag abnormalities earlier than conventional scans and offer tailored treatment recommendations. At Greyhound Research, we believe this two-pronged AI application, one improving early infectious disease detection, the other transforming precision oncology, signals a strategic shift. AI in Indian hospitals is no longer experimental. It's operational and increasingly central to future clinical models. At Mount Sinai in New York, researchers developed and implemented Deep Patient, a deep learning model trained on approximately 700,000 electronic health records (EHRs). Designed to anticipate rather than just react, the system identified patients at elevated risk for developing conditions such as schizophrenia and various cancers by uncovering complex, often hidden patterns in historical clinical data. According to findings published in Nature Scientific Reports, Deep Patient demonstrated the potential of deep learning models to predict disease trajectories well before clinical symptoms surfaced, offering valuable windows for early intervention. But what truly distinguished this initiative was not just its predictive accuracy, it was its integration into clinical practice. Deep Patient insights were embedded directly into Mount Sinai's electronic health record workflows, ensuring that physicians could act on critical risk signals without having to toggle between disconnected systems. In an era where every extra step in a workflow is a point of failure, this seamless integration proved just as important as the sophistication of the AI itself. At Karolinska University Hospital in Sweden, emergency department operations have been significantly enhanced through a series of technology-driven interventions. Rather than deploying a standalone AI triage assistant, Karolinska implemented a broader AI-supported analytics platform known as CRAB, Cognitive Reasoning and Analysis of Big Data. This system enables continuous monitoring of clinical outcomes, providing real-time feedback loops that allow frontline teams to identify performance gaps and recalibrate care processes quickly. According to Healthcare in Europe, CRAB has contributed to Karolinska's low complication rates and reputation for extreme transparency in patient care. Parallel to this, the emergency department at Karolinska's Hudding campus deployed a digital crowding tool, a dynamic system that monitors patient inflows, resource availability, and departmental bottlenecks. Combined with enhanced specialist availability and cross-team collaboration, these initiatives have led to a measurable reduction in patient waiting times by approximately 30 minutes, as reported by Karolinska Hospital News. Rather than treating AI as a substitute for clinical intuition, Karolinska demonstrates how intelligent systems can augment operational transparency and workflow agility, key pillars for sustainable emergency care modernization. At Hospital das Clínicas in São Paulo, Brazil, efforts to improve the early diagnosis and management of arboviral infections, such as dengue and Zika, have intensified over recent years. Researchers affiliated with the institution have contributed to large-scale surveillance studies tracking viral incidents and clinical outcomes across Brazilian blood centers, as reported in PubMed. While specific public records of a clinical decision support system, CDSS, deployment at Hospital das Clínicas remain limited, broader AI-driven research initiatives have demonstrated the potential to accelerate diagnostic timelines and optimize patient triage for high-fever admissions, a persistent operational challenge during dengue and Zika outbreaks. Additionally, clinical guidelines published by the Pan-American Health Organization, PAHO, stress the importance of structured decision support in improving outcomes during arboviral epidemics. At Greyhound Research, we believe the lesson is universal. In the fight against emerging infectious diseases, the ownership clinicians feel in shaping and trusting AI tools is as crucial as the algorithms themselves. These examples share a common DNA: alignment between technology, people, and purpose. AI was not parachuted in as a fix-all. It was co-developed and carefully woven into the existing clinical fabric. However, case studies are only powerful if they're transferable. At Greyhound Research, we track where models succeed and, more importantly, why. What we've learned is simple. AI becomes transformative only when clinicians are co-authors in its design and guardians of its evolution. The hidden fault line: why most hospitals fail at AI in clinical decision support. Too many hospital boards fall into the same trap. They treat AI like a capital purchase, not a strategic capability. They see a shiny demo, approve a pilot, and assume the hard work is done. What follows is entirely predictable. Systems that clinicians don't trust, alerts that get ignored, and pilots that never scale beyond isolated departments. The fundamental problem isn't technology failure. It's organizational failure. AI in healthcare, especially in clinical decision support, demands a complete rethinking of how hospitals align technology with clinical workflows. Instead, what we often see is a transactional mindset, AI treated like a procurement checklist, rather than as a living, breathing extension of clinical decision-making. At the heart of these failed deployments is a profound lack of alignment. AI is frequently procured without involving the very people it is meant to serve, the clinicians. Decisions are made in boardrooms based on vendor promises, without real-world clinical input or frontline validation. As a result, the AI tools arrive disconnected from clinical reality. They are evaluated through KPIs that measure uptime and dashboard activity, not through patient outcomes, time to treatment, or clinician adoption. Training is treated as a one-time onboarding event, not the continuous, evolving relationship it needs to be. No wonder most pilots stall. Greyhound field notes from our work with health systems in Brazil and Mexico City reveal a recurring and troubling pattern. Clinical decision support systems, CDSS, developed and trained primarily on US or European datasets, often underperform when deployed in local contexts without adaptation. Across multiple deployments, we observe models struggling to maintain diagnostic sensitivity and specificity, a finding echoed in broader research. For instance, a Stanford University study found that chest X-ray algorithms trained on American datasets performed significantly worse when tested on patient populations from India and China. Similarly, the World Health Organization's 2021 guidance on ethics and governance of artificial intelligence for health warns that AI models trained predominantly on data from high-income countries risk amplifying global health inequities, particularly in diagnostic applications. These gaps are not theoretical. Differences in disease prevalence, genetic diversity, clinical documentation styles, and socioeconomic factors mean that models calibrated for Boston or Berlin can falter badly in Bogota or Brasilia. Without active retraining and local validation, AI becomes not a safety net, but a new point of clinical risk. At Greyhound Research, we believe that no matter how sophisticated a model appears in a controlled setting, its true value is tested in the messy, dynamic, and diverse realities of frontline healthcare. In addition to these challenges, hospitals face systemic hurdles such as poor data interoperability across systems, complex EHR integrations, and rampant alert fatigue. Greyhound field notes from Asia-Pacific deployments show that even well-designed CDSS systems suffer when clinicians are overwhelmed by irrelevant or excessive alerts, often leading teams to mute or bypass critical notifications, neutralizing the system's intended safety benefits. In one striking example, a radiology AI flagged tuberculosis inaccurately in nearly 12% of cases in a major public hospital in Sao Paulo, simply because the model hadn't been trained on regional prevalence data. This wasn't just a minor glitch, it led to delayed treatment protocols, unnecessary retests, and most damagingly, clinician distrust in the system itself. These failures are compounded by three systemic barriers: poor input data quality, lack of explainability in AI models, and the absence of clinician trust. A CDSS model that misfires once may be tolerated. A model that cannot explain its reasoning will never recover trust. Our field observations align with published research. Models must not only work, they must justify their choices in a language clinicians understand. Trust, once broken, is almost impossible to rebuild. CDSS tools, no matter how sophisticated, are only as useful as the confidence clinicians place in them. A system that offers incorrect advice, even a few times, becomes the system that gets silently bypassed on the ward. Over time, these abandoned systems become costly sunk investments, technology that looks good on a strategy slide, but has no heartbeat in the daily rhythm of clinical practice. For AI in clinical decision support to succeed, hospitals must rethink not just what they buy, but how they embed, measure, and nurture it. Successful deployments involve clinicians from the first demo to the post-deployment review. They measure success in clinical metrics, diagnostic accuracy, reduction in time to treatment, improvements in patient outcomes, not just financial spreadsheets. They invest in governance, continuous retraining, and model recalibration as core parts of operations, not afterthoughts. The reality is simple. AI is not a one-time buy. It's a living partnership with your clinicians. And if hospitals can't align technology ambition with clinical authenticity, even the most powerful AI systems will wither on the vine. Failure in AI deployments rarely begins in the software. It begins in the silence between departments. At Greyhound Research, we call out these hidden gaps: governance without grit, strategy without staffing, and techbot without trust. AI won't fix institutional disconnection, but it will expose it. The unseen economics. Why accuracy is the true ROI of clinical AI. When it comes to AI in clinical decision support, the boardroom conversation often gravitates towards cost savings, efficiency boosts, and productivity charts. But the real economics of AI, the ones that truly matter to patient safety and hospital survival, lie elsewhere. They lie in accuracy, in getting the diagnosis right the first time, in intervening minutes earlier, in preventing the cascade of errors that starts when a subtle clinical cue is missed. Let's talk numbers. Medical errors impose a staggering cost on global healthcare systems, both financially and reputationally. In the United States alone, preventable adverse events, from surgical complications to hospital-acquired infections, are estimated to cost the system over $17.1 billion annually, according to the Agency for Healthcare Research and Quality, HRQ. Among these, diagnostic errors are particularly lethal, contributing to nearly 10% of patient deaths and up to 17% of all hospital-related adverse events, as reported in the BMJ. The financial impact is only part of the story. One misdiagnosis can lead to multi-million-dollar litigation, regulatory action, public backlash, and, perhaps most damaging, the erosion of institutional trust. At Greyhound Research, we believe the cost of inaccuracy in care delivery is no longer just clinical, it's existential. Now flip that equation. Early clinical trials show that when artificial intelligence is used to flag stroke risks in emergency settings, it can meaningfully accelerate time to treatment. A randomized study by UT Health Houston found that AI-driven triage tools reduce time to endovascular thrombectomy by an average of 11 minutes in patients with large vessel occlusion, LVO strokes. That might sound modest, but in stroke care, every minute counts. According to the American Heart Association, a 15-minute reduction in treatment delay can translate to an additional month of disability-free life. Hospitals across North America and Asia, including systems in Toronto and Tokyo, are now embedding AI into imaging triage and emergency workflows, reporting measurable gains in door-to-needle time and improved discharge outcomes. In a health system where every occupied bed carries financial and human cost, speeding up recovery without sacrificing quality is no longer an optimization, it's an obligation. In the United Kingdom, the National Health Service, NHS, has actively explored AI-based triage tools to ease the burden on general practitioners and streamline patient access. One example is the smart triage system developed by Rapid Health, which was deployed at the Groves Medical Center in Surrey in southwest London. According to an NHS-backed evaluation, the tool reduced GP waiting times by 73%, enabling autonomous triage based on clinical urgency rather than a first-come, first-served queue. This helped free up physician bandwidth for more complex cases improving care prioritization without compromising safety. Other AI pilots, like Babylon Health's Ask A&E app, have had mixed outcomes. A deployment at Royal Berkshire NHS Foundation Trust, for instance, failed to meaningfully reduce emergency department attendances and was subsequently not renewed. NHS for sale. These mixed results underscore a broader point. While AI can expand clinical capacity and reduce inefficiencies, its real value lies in precision design, careful governance, and deployment tuned to the local context. At Greyhound Research, we believe the lesson is clear. AI won't fix patient flow by default, but when built around the clinician, it can radically rewire where human attention is spent. Our most recent Greyhound Pulse 2025 Hospital Innovation Tracker underlines the duality hospitals are wrestling with. While 66% of hospital CIOs globally have initiated AI pilots in diagnostic workflows, only 19% report that these pilots have successfully scaled beyond isolated departments. Even more telling, 71% of respondents cited clinician resistance or a lack of seamless workflow integration as the top barriers to adoption. The numbers tell a clear story. The appetite for AI is strong, but without meaningful clinical alignment and operational embedding, most initiatives remain stuck in perpetual pilot mode, high on promise, low on impact. Savings in healthcare are often misunderstood. They don't always show up as bold figures on a financial spreadsheet. More often, they surface as avoided costs, the scans that don't need to be repeated, the complications that never escalate, and the readmissions that never occur. When AI in clinical decision support helps reduce unnecessary imaging, even by modest margins, the downstream impact is far-reaching. Patients avoid needless radiation. Clinicians are spared the distraction of incidental findings that lead to low-value follow-ups. Imaging equipment is freed up for urgent, revenue-generating cases that can't wait. Multiple studies reinforce this. A recent analysis in the Journal of the American College of Radiology, JCR, showed that embedding AI into imaging order entry systems increased structured indication use and improved the appropriateness of imaging requests. Another study published via PubMed found that AI-assisted indication selection significantly raised the likelihood of orders meeting clinical appropriateness criteria. At Greyhound Research, we believe this is the real ROI of AI. Not flashy upfront savings, but silent systemic gains that compound over time. AI doesn't just trim budgets. It recalibrates the very way clinical attention is prioritized. According to the Greyhound Pulse 2025 Boardroom Health Tech Priority Survey, 72% of hospital CFOs now agree that AI's ROI must be evaluated not just through traditional operational savings, but through broader clinical and medical legal metrics, quality-adjusted life years, CALIs, clinical throughput, and litigation avoidance. The new reality is clear. In an AI-driven future, what matters most is not how cheaply you can deliver care, but how accurately you can deliver it. It's not just about what you save, it's about what you no longer lose. At Greyhound Research, we believe accuracy is not a clinical luxury. It is a financial imperative. Hospitals that treat AI as a tool to avoid cost mistakes, not just reduce cost centers, will future-proof both care and cash flow. Precision is the new profitability. The next leap: how Federated AI will redefine clinical decision support. As healthcare systems lean deeper into digital transformation, the next frontier for clinical decision support, CDSS, isn't just about building smarter tools, it's about building smarter collaborations. The future of CDSS will belong to hospitals that understand that intelligence gains are no longer confined within four walls. They will be driven by collective learning across institutions and geographies without ever compromising patient privacy. At Greyhound Research, we believe that federated AI architectures will fundamentally change the way hospitals think about decision support systems. In a federated model, hospitals can jointly train AI models on a collective pool of insights without ever sharing raw patient-level data. Each hospital retains its data locally, but contributes to the improvement of a common model. The advantage? Vastly richer training datasets that reflect real-world variability, disease phenotypes, treatment responses, genetic backgrounds, without breaching regulatory walls. Federated AI is no longer theoretical. It's already reshaping cancer diagnostics in markets that prioritize both data privacy and diagnostic precision. In Singapore, the MetaLight platform, developed by GelloX Biotech in partnership with QM'd Asia and powered by Intel, uses federated learning to analyze 3D medical imaging data across multiple hospitals without transferring patient records. According to Intel's case study, the system demonstrated improved accuracy in early detection of cervical and lung cancers, while remaining fully compliant with local data protection laws. Similar collaborations are taking shape in Estonia and Switzerland, where regional hospital networks are using federated learning to train more generalizable AI models for oncology, models that benefit from data diversity without breaching residency regulations. A recent review published by Greyhound Research highlights how federated systems consistently outperform siloed AI models in predictive accuracy, particularly in cancer staging and prognosis. At Greyhound Research, we see this shift as more than a technical evolution. Federated AI is a strategic response to a long-standing trade-off: the need to innovate without compromising confidentiality. In precision oncology, where the stakes are high and the datasets fragmented, this approach doesn't just future-proof your models, it future-proofs your ethics. Greyhound Pulse 2025 projects that federated CDSS models could boost diagnostic accuracy by up to 18% in oncology and rare disease cohorts over the next 5 years. The impact is not just academic. Early, accurate diagnosis in these categories means earlier interventions, lower treatment burdens, and substantially better patient outcomes, all of which cascade into measurable savings across the continuum of care. Greyhound field notes from a regional cancer institute in Eastern Europe reinforce this optimism. After participating in a federated AI pilot program focused on rare tumor types, the institute reported a twofold increase in early-stage diagnoses of low-incidence cancers. Importantly, clinicians at the site noted that model recommendations felt closer to clinical intuition, a crucial trust-building factor that historically undermined traditional, rigid CDSS systems. The difference was that federated AI reflected a broader, richer understanding of diagnostic patterns, including those rarely seen in isolated hospital datasets. The goal ahead is clear: a future where your CDSS doesn't just learn from your patients, but from the world securely, ethically, and continuously. Federated AI offers a path to decision support systems that grow stronger without growing riskier. Systems that respect patient sovereignty while enhancing physician judgment. Systems that shift healthcare from reactive firefighting to proactive pattern recognition. But that future won't build itself. Hospitals that want to benefit from federated CDSS will need to invest not just in AI tools, but in governance structures, interoperability standards, and collaborative mindsets. It's no longer just about protecting what you know, it's about expanding what you can predict by standing on the collective shoulders of global clinical knowledge. Moving forward, federated systems must also solve for ethical AI. At Greyhound Research, we believe this means ensuring algorithmic fairness across diverse populations, standardizing data representation formats, and designing governance models that put clinicians in the loop. The goal isn't automation, it's augmentation. Future-ready CDSS must lighten the cognitive load, not add complexity to an already burdened workforce. At Greyhound Research, we believe the next great leap in clinical decision-making won't happen within the four walls of a hospital. It will happen when hospitals learn to think beyond them. We believe the next wave of clinical advantage won't come from the most powerful hospital, but the most connected one. Federated AI is how we decentralize intelligence without decentralizing integrity. At Greyhound Research, we see this as the blueprint for global resilience, built locally. A roadmap for hospital owners and management, from curiosity to capability. If you're on the board or in the leadership suite, here's the path you must chart to move from curiosity about AI to real clinical capability. 1/Abandon the turnkey fantasy. AI in clinical workflows is not a product you install. It's a living system that evolves, degrades, and needs nurturing. If you're expecting a plug-and-play model, you're already planning for failure. 2/Involve frontline staff from day zero. AI must be built for those who will actually use it: the doctors, nurses, and clinical ops teams. Involve them in vendor demos, pilot designs, and evaluation criteria. Greyhound field notes show that hospitals involving clinicians early see 3x higher adoption rates post-launch. 3/Define your first win. Narrow but impactful. Start small but sharp. Reducing diagnostic delays in a single specialty, for instance, creates measurable clinical value and builds internal credibility. Broad, vague objectives dilute focus and doom early projects. 4/Measure success in clinical outcomes, not software adoption. Dashboards don't save lives. Track changes in diagnostic accuracy, clinician decision confidence, patient outcomes, and time to treatment. Let clinical impact, not IT deployment, be your North Star. 5/Build a multi-year adoption plan. AI maturity is not a quarterly metric. It unfolds over years, Pilot, refine, expand, retrain. Hospitals with a 3-year phased rollout plan, according to Greyhound Pulse 2025, report twice the clinical trust compared to those chasing quick wins. 6/establish an AI governance board. AI is not just technology. It is ethics, law, data stewardship, and frontline reality woven together. Build a governance board blending tech leads, bioethicists, clinicians, data scientists, and legal experts, not just CIOs and CFOs. 7/bake retraining and recalibration into contracts. AI models decay with time. Shifting patient demographics, new clinical practices, and emerging diseases will blunt any static model. Ensure contracts include regular retraining cycles, outcome audits, and a governance model for continuous improvement. 8/ align AI goals with broader clinical strategy. AI should not be a moonshot project running parallel to your actual clinical priorities. It must explicitly serve and strengthen core hospital goals, quality improvement, patient safety, throughput enhancement, and clinician well-being. 9/design for clinician trust, not executive showcase. Flashy AI tools that impress in boardrooms, but frustrate in wards are dead on arrival. Systems must be transparent, clinically explainable, and non-intrusive. Clinicians should feel that AI amplifies their instincts, not competes with them. 10/accept that success will be uneven, and course correct ruthlessly. Some pilots will fail. Some models will underperform. The winners will not be those who fear these setbacks, but those who anticipate them, learn fast, and adapt aggressively. Build a culture that sees course correction as strength, not shame. At Greyhound Research, we believe that healthcare transformation doesn't begin with code, it begins with courage. Courage from hospital owners and management to demand real change. Courage from clinicians to embrace new tools. And courage from technologists to admit when a model isn't ready for deployment. Hospital owners and management who get this right will build systems that don't just respond to illness, they anticipate it. They won't just buy tools, they'll build capabilities. And that's where the real transformation lies. Not in a dashboard, but in a diagnosis made smarter, faster, and more human than ever before. Analyst in focus, Sanchit Gogia. Sanchit Gogia, or SVG as he is popularly known, is a globally recognized technology analyst, innovation strategist, digital consultant, and board advisor. SVG is the chief analyst, founder and CEO of Greyhound Research, a global, award-winning technology research, advisory, consulting, and education firm. Greyhound Research works closely with global organizations, their CXOs, and the board of directors on technology and digital transformation decisions. SVG is also the founder and CEO of the House of Greyhound, an eclectic venture focusing on interdisciplinary innovation. Copyright policy. All content contained on the Greyhound Research website is protected by copyright law and may not be reproduced, distributed, transmitted, displayed, published, or broadcast without the prior written permission of Greyhound Research or, in the case of third-party materials, the prior written consent of the copyright owner of that content. You may not alter, delete, obscure, or conceal any trademark, copyright, or other notice appearing in any Greyhound Research content. We request our readers not to copy Greyhound Research content and not republish or redistribute them, in whole or partially, via emails or republishing them in any media, including websites, newsletters, or intranets. We understand that you may want to share this content with others, so we've added tools under each content piece that allow you to share the content. If you have any questions, please get in touch with our community relations team at connect@thoffer.com.